2, 3. Oops, sorry. All right.
Good morning. Are you ready? Shall we wait another minute? Yes, no? Yes? Okay. So I'm Dr. Maresh Miselli, and we're going to start today with the second part of inflammation and repair. I hope you had some time to start studying the first lecture that I gave you yesterday. So today we're going to continue. I'm going to remind you the features of the block. I don't know if you noticed, but the block just became a little bit smaller, and it's getting smaller and smaller the more you progress into the block. This is lecture number 2, as I said. You have another lecture on Tuesday morning. You also have the CPC next week and the problem-solving exercises. And don't forget the repetitio. Repeat. You got to read more than once. This has a lot of theoretical information, this block. Today's lecture's objectives include morphological patterns of acute inflammation, the mechanisms, mediators, and morphological patterns of chronic inflammation. And based on that, we will take a look at some potential therapeutic strategies. Now, this is a quick reminder of the floor plan, if you want, of the whole chapter. We learned yesterday about inflammation and the key participants in the process of acute inflammation. Today, we're going to take a look at these morphologic patterns of acute inflammation, and we start looking at the outcomes of acute inflammation. We'll start the day with chronic inflammation, and next lecture, we will talk about the tissue repair. Before we get into these morphologic patterns of inflammation, I thought we'd take 5 minutes to talk about different kinds of cells involved in inflammation, because inflammation basically in the end is about all kinds of cells. I keep telling you about the monocyte, the poly, and lymphocyte, and I don't know if you remember the cells. So if you agree, we're gonna go quickly through the cells for a few minutes. I showed you this picture of hematopoiesis yesterday. I don't know if you remember all these precursors. What I do care right now from you is to remember the final shapes and forms of these different cells. This is the red line. This is a red blood cells. I want you to be able to recognize an erythrocyte. These are the platelets, little tiny specks, platelets. And in the middle, you have the white blood cells classified into granulocytes and agranulocytes or monocytes. Basophil, the blue one, eosinophil, the red one, and polys, the one with a nucleus which has 3 to 5 lobes. In the agranulocytes class, you will need to be able to recognize the lymphocyte and the monocyte. I want you to look not only at the color, but at the relative sizes of these cells. Lymphocyte is smaller, monocyte is the biggest cell. Now, you hear the word eosin, eosinophilic, hematoxylin eosin. This is how the stain looks like. This is the color. So when you hear eosinophilic, you think pink, right? So these are the main circulating cells. The immature neutrophil, the so-called band, platelet, lots of erythrocytes. This is the poly. Notice the nucleus, multilobated nucleus. Very, very easy to recognize, even in low power. Eosinophil, really, really easy to recognize under the microscope. It has these small red, bright granules, sometimes covering the entire nucleus. Basophil, the same, except these granules are chunky and they are dark blue. And monocytes are the biggest cells. They have abundant, lighter cytoplasm, sometimes with vacuoles in it if the monocyte fed. And this fetal-like nucleus. This is a drawing showing you the same thing. Granulocytes, eosinophil, basophil, poly, or neutrophil, lymphocyte, and monocyte. I don't want to give you a lecture in histology. I want you just to have these pictures handy when you learn about inflammation, because we're going to talk about all of these cells. Polys, eosinophil, basophil and mast cell. And here are some information about the mast cells. We're going to spend a little time here. Lymphocytes, you have to recognize the lymphocytes. They're actually very easy to recognize. They have this round nucleus surrounded by very, very tiny film of cytoplasm. And this nucleus is dark blue. And it's almost like a perfect circle. Now, I want to spend a little bit of time to describe this cell. Anybody knows what this cell is? This is one serious cell. My professor, my mentor, Dr. Deligdish, said, if you see plasma cell, they mean business. I want you to remember that. If you see plasma cells, they mean business. This is the plasma cell. How we describe this cell, I want you to be able to recognize the plasma cell. It's an ovoid cell, look at the shape, abundant light cytoplasm with a little area of clearing next to the nucleus. That's called a perinuclear half. An eccentric nucleus, which means it's not in the center, it's on the side. Eccentric nucleus, which has chunky chromatin, described as clock face. Now, to my utter amazement, a few years, I realized that some of my students didn't know what a clock face means. This is a classical clock with the numbers. So chromatin looks like it's distributed like the numbers on a clock. Hence the description, clock face nucleus. Okay, mononuclear macrophages. So you do know that while they're in the blood, circulating cells, they're called monocytes. When they get into the tissue, they're called macrophages. They have an elongated, irregular shape that reflects their amoeboid wandering nature, and they may contain multiple vacuoles of various size in the cytoplasm. So this is a monocyte. Now I'm going to start asking you, what is this? Poly, yes, a neutrophil. And this? No, lymphocyte. Plasma cell has more cytoplasm than this. And you'll see here, the nucleus is pretty occupying the whole surface. Very, very tiny cytoplasm. And you don't really see that. I see what you mean by this could be a perinuclear half, but it's not. This is just a lymphocyte. Megakaryocyte, this is a precursor. These are the platelets. Tiny little specks. Let's try again. Poly, band, poly, what's this? Monocyte, big size, some vacuoles in here. Sometimes these nuclei get stringy, elongated. Here it takes a fetal form. Lymphocyte, yes? Poly, lymphocyte, eos. You see a lot of red here in the cytoplasm. Trust me, you have to see it under the microscope. The granules are so bright, red bright, you cannot miss that cell. Lymphocyte, poly, mono, lymphocyte, basophil, lymphocyte. You got it? Let's see here. Dilated blood vessel. How do I know this is a dilated blood vessel? I can see the outline of the vessel. I can see the endothelial cells. Besides, there's a lot of erythrocytes inside here. So this is a dilated blood vessel. Lymphocyte, poly. Look at the nucleus. Poly. You got it? Good. Here's your first damn moment. I named my dog 5 miles, so I could tell everyone that I walk 5 miles every day. All right, back to our subject. So you learned yesterday about the 5 cardinal signs of inflammation. You remember them? Tumor, rubor, calor, dolor, funcțioleza. And you learned that morphologic hallmarks of acute inflammatory reactions include dilation of small blood vessels with accumulation of leukocytes and fluid in the extravascular tissue. These are the general morphologic hallmarks of all acute inflammatory reaction, but often superimposed on these general features depending on different factors, such as the severity of the reaction, the specific cause, the particular tissue or site involved, we can see special morphologic patterns. Most important ones that we're going to learn about today are serous inflammation, fibrinous inflammation, purulent inflammation and abscesses, and ulcers, which are more like a consequence of these acute inflammatory processes. And it's very important to recognize the gross and microscopic pattern of inflammation, because these will give you clues about the underlying cause. And when you want to treat an inflammatory process, you want to go to the cause. You don't want to treat only the symptoms. Let's start with a serous inflammation. How do we define serous inflammation? Serous inflammation is exudation of cell-poor fluid into spaces created by injury to surface epithelia or into body cavities lined by peritoneum, pleura, or pericardium. Now, grossly, they look like this. Here's an example of a skin blister resulting from a burn or a viral infection. How would you describe that? Do you recognize any sign of inflammation here? Which one? What's that? Exactly, rubor, redness, which I told you yesterday that clinically is called erythema. So around these blisters, these swellings, if you want, we see all this redness area, erythematous area. And also through the thin wall of these blisters, you can appreciate that these vesicles are filled with some yellowish fluid, right? Now, if you take a section here from this area, what you're going to see is this. This is the skin, keratinized. This is the layer of keratin on top. Keratinized squamous epithelium, and this is the subcutaneous tissue. Between the epidermis and dermis, you see this space, the white space. This is where the fluid was. This is the so-called serous effusion. Now, grossly, we describe this serous effusion as thin, as opposed to viscous, thin fluid, straw colored, so light yellow. It does not contain large number of leukocytes and usually does not contain microorganisms. This is a quick reminder from yesterday to remind you of the difference between effusion and edema. So both effusion and edema are fluid accumulated outside the vessel, the fluid that left the blood vessel and went either in a space, in which case we call it a diffusion, or in a soft tissue, in which case we call it an edema. And they can be classified, as I said yesterday, into exudate or transudate. Here's a higher power, a close-up magnification of this serous inflammation. Here you see the lesion grossly. You see this erythematous area, and you see the tumor also, tumor rubor, the swelling. This is the blister, a blister on the skin surrounded by this erythematous area. And here in the close-up, in the microscopic section, you see this area of fluid accumulation between the epidermis and the dermis. Also, you can see some inflammatory infiltrate derived from the dermal capillaries. But if you look at the microscope in higher power, you'll see this is a paucicellular exudate. Do you know what paucicellular means? Pauci. Few cells, very few cells, as opposed to rich. Okay, here's another example. This is an allergic nasal pseudopolyp where you see, if you look in the background, you see there's some greenish, if you want, fluid on the slide. That is the serous exudate, which contains, aside from that fluid, these strands of mucin, all of these little pink lines, and the cell that predominates here are the, anybody recognize that? Red bright granules. Eosinophils, yes. All right, so that was serous inflammation. Fibrinous inflammation. How do we define fibrinous inflammation? Fibrinous exudate will develop when the vascular leaks are large or there is a local procoagulant stimulus. This is specific to inflammation of the lining of the body cavities. In meninges, you see that. You can see that in pericardium and in pleura. What you see in this, what is specific to this fibrinous inflammation is the presence of fibrinogen, which is a high molecular weight protein, which leaves the blood and gets into this extravascular fluid. Fibrin will be deposited in the extracellular space and will microscopically present as this eosinophilic meshwork or threads, or as an amorphous coagulum. Here you see a pericardial sac which was open. This is the heart here. And normally the surface of the pericardium should be like this, smooth and bluish. Instead, it's covered by this granular pink deposits. This is the part of the fibrinous exudate. And if you take a section from that, you see here the normal pericardium, and here you see this pink meshwork of fibrin. The consequence of this fibrinous inflammation are two. Either it goes away or it stays. Resolution, which means it will be dissolved by fibrinolysis and cleared by the macrophages, or it stays and will get organized. Organization means conversion of this fibrinous exudate into scar tissue by ingrowth of fibroblasts and blood vessels. And the possible consequence of this organization will be obliteration maybe of the space. Here's another example of pericardial sac opening, and between these two layers of pericardium, you see these fibrin strands. And in microscopy, you see this is the pericardium, and this is the so-called coagulum of fibrin. And also you can notice here these blue dots, those are inflammatory cells. Okay, the next type of inflammation is the purulent or suppurative inflammation or abscess. Now, grossly, you see here, anybody knows what organ is this? Look at the color. This is the normal color. In order to recognize the pathology, as I said before, and I'm going to say ad nauseam until the year is over, in order to know the pathology, you will need to know the normal. You need to know the histology. So this is, anybody? What's the organ? You should have a hint here. Lung. Yes, this is lung. Now, is this normal lung? Something is abnormal in this lung. You see these white little dots, white spaces here? That's not normal. That's pus, actually. So these are multiple bacterial abscesses shown by these arrows in a lung with bronchopneumonia. If you take a section from here, section of the tissue, and look at it under the microscope in pathology, you will see this. This is called an abscess. And how do we describe an abscess? What is the content of an abscess? In the middle, you'll see a lot of necrotic neutrophils and cellular debris. On the edge of this necrotic center, you may see viable polys, and around it, you will see this congested, dilated blood vessels. This is the blood vessels. How do I know? By the color. All of these are erythrocytes, and by the shape. Okay? Congested blood vessels. So pus is an exudate consisting of polys, the liquefied debris of necrotic cells, and edema fluid. The most frequent cause, as you know, is infection with pyogenic bacteria, for instance, staphylococci. What is an abscess is a localized collection of pus, called by suppuration, buried in a tissue, an organ, or a confined spaces. The consequences of the presence of an abscess is walling off of the abscess, and ultimately replacing the abscess by connective tissue, or when this abscess is persistent, or when it's located in some critical locations, for instance, in the brain, they may have to be treated, they may have to be removed surgically. Now, here's an example of bacterial pneumonia. Which side is the normal one? Left or right? Which one is the normal lung? Guys, histology. This one? Okay. Why? Why do you see here? White. There's a lot of white. You should see a lot of white. That's air in the alveolar spaces. Here, you see a lot of blue. So here, if you pay attention, you can actually make out the outlines of the alveolar spaces. That is very important because that means the original structure of the organ is maintained. And this is important when you're talking about the repair process. Okay, you will have minimum loss of function if you still have some maintained structure. So here you see acute inflammatory exudate consisting of numerous neutrophils within alveolar spaces. Can you tell that those are neutrophils? I can't, not at this power. So we have to take their word. That's what Robin said. Now, let's move higher up. What do we distinguish here? I see a lot of outlines with red. These are the congested blood vessels. These are alveolar spaces. I'm not talking about this area yet. I'm looking around it. Alveolar spaces, congested vessels, small vessels, and inside the alveolar spaces, I see these inflammatory cells. Can I classify them as polys or monos? Not really. Maybe I can see some polys here. But what I see in the center is the same alveolar structure maintained, but with a lot of inflammatory cells. There's a lot of blue. So those are inflammatory cells. And as I said, it's really important that this structure is still maintained. Now I can tell. Now I can describe the cells. So this is an alveolar space, congested blood vessels. You can tell that these are blood vessels, right? Because of the erythrocytes, the red blood cells. And inside, I see polys. Look at this nucleus. Polys, a lot of polys, a lot of polys. So this is the typical image for a bacterial infection. Clinically, do you know how these patients present? Clinically, patient with alveolar spaces filled with polys, patients with bacterial infection, in other words, they will have productive cough and purulent yellow sputum. Here's another example of a purulent inflammation. Which part of this brain is normal? This one or this one? Anterior or posterior? This is normal, yes, because here I can see through these leptomeninges, there's some yellowish, whitish film of fluid. And if I take a section from this area, I see neural tissue here, some congested blood vessels, and a lot of inflammatory cells. So this is an acute suppurative inflammation of pneumococcal meningitis. Here's another example. This is called a furuncle or a boil, which is an abscess involving a hair follicle, usually caused by a staphylococcal infection. How would you describe this? What are the two signs of inflammation that you see here? Tumor rubor, right? I don't know color, I have to touch it. Dolor, I have to ask. So I see tumor rubor, I see a swelling, and I see redness, I see erythema, and I see some white spots here. This is the pus. Now, here's another example. This is called carbuncle, which is a cluster of furuncles that are subcutaneously connected. This is an exaggerated suppurative inflammation occurring usually in patients with uncontrolled diabetes. Now, you do notice the large area of the swelling and the erythema around the swelling. If you take a section and you look at it under the microscope, what do you see? What is this here? Stratified squamous epithelium, called, in other words, skin. That's the skin, guys. You have to recognize the skin. Skin here, and underneath, I see chaos. Let's start to make some light in this chaos. What do I identify here? It's a round outline with some red dots in it. Another one here, longitudinal section. These are the congested blood vessels with erythrocytes in them. Now squint your eyes and try to identify these darker pink lines. These are the fibrin. You notice that? Can you see it? Look at the image. So these are the fibrin strands. And also, like little pepper specks, there's a lot of blue here. These are the inflammatory cells. Okay? Who's this guy? History, anybody? Yes. Winston Churchill, he said, a fanatic is someone who won't change his mind and won't change the subject. I will not change the subject. Let's continue with the subject and let's move on to the last form of inflammation, of pattern of acute inflammation. How do we define an ulcer? An ulcer is a local defect or excavation of the surface of an organ or a tissue produced by sloughing or shedding of inflamed necrotic tissue. This is an ulcer here. This is a duodenum, a section from a duodenum. This is an ulcer. You notice the area around the ulcer does not have these folds. It could be edema, it could be a scar. It depends on the age of the inflammation. In an acute inflammation, you might see edema. If it's chronic, it's becoming fibrotic and you can see a scar. Now, where do you see these ulcers? Most commonly in the mucosa of the mouth, stomach, intestines, or genitourinary tract. And you can also see them on the skin and subcutaneous tissue of the lower extremities, and mainly in the older people with circulatory disturbances, which are predisposed to ischemic necrosis. Now, what do we see microscopically? We can see acute and chronic inflammation, which they most of the time coexist in ulcers. And the more chronic the ulcer is, the more you will see scarring, this fibroblast proliferation here at the edges of the ulcer and in the base of the ulcer. You may also see some inflammatory infiltrate, as I said, depending on the age of the ulcer. Here's a very old ulcer. How do I know it's old? Because this is very whitish, indurated, fibrotic tissue. This is the normal tissue. This is the normal muscle. This is the defect in the mucosa, normal mucosa, a defect in the mucosa. This is the ulcer. This is the base of the ulcer. Underneath, I have this, I'm looking at this whitish, indurated, sclerotic area of the scar. Let's review the dictionary so far. Edema and diffusion. Edema in the tissue, effusion in a body cavity. Got that? Nod? Yes? No? Yes, good. Transudate or exudate. Every fluid that goes out of the vessel, we classify in the lab, either in a transudate or an exudate. The most important criteria here is the protein content. Low protein content, transudate, high protein content, exudate. Now, we just learned about different types of exudate. We classify them into serous, which is an exudate which lacks large number of inflammatory cells, usually is straw-like, pale yellow. If it has a little bit of blood in it, we call it serosanguinous exudate. It contains erythrocytes, which gives a red color. Fibrinous exudate will, as the name says, contains large amounts of fibrin, and purulent exudate is the pus, the exudate with high inflammatory cell content. You usually see that with bacterial infections. You saw this slide yesterday towards the end of this lecture. We were talking about the inflammation outcomes, and I told you about acute inflammation can evolve into complete resolution with restoration of normal function or very little loss of function, or development of an abscess, which heals usually with fibrosis, or healing directly with fibrosis if there's a large defect, or in cases of a protracted inflammation, it can progress in what we call chronic inflammation. Now let's move on into the chronic inflammation. And I just said it's defined as a process, inflammatory process of prolonged duration, weeks, months, or even years. So in this case, in the case of chronic inflammation, tissue injury, inflammatory process, and attempts at repair will coexist in varying combinations. It may follow acute inflammation, or it can start de novo without that loud phase of acute inflammation. What are the causes? Persistent infection, usually by microorganisms, difficult to eradicate, and you know the TB infection, treponema, different viruses of fungi. Also another cause, hypersensitive disease caused by excessive and inappropriate activation of the immune system. Also prolonged exposure to potential toxic agents, which can be either exogenous, example, silica, when you learn about this in the lung pathology, or they can be endogenous as in cholesterol crystals in atherosclerosis. And we're going to take some time to talk about a specific pattern of a chronic inflammation called granulomatous inflammation. And I'm going to show you a lot of pictures of that. Now, morphologic features of chronic inflammation, what do you see? when you're looking at a slide taken from a tissue with chronic inflammation. First of all, we're going to talk about cells. You will see inflammation with mononuclear cells, macrophages, lymphocytes, and plasma cells, as opposed to neutrophils, which is what you see in an acute inflammation. Now, I want to mention here that this is the rule, but there are exceptions. If you remember the slide that I showed you yesterday with the time frame, when I said in acute inflammation, in the first 24 hours, you will see polys. That is a rule. After that, the polys will be replaced by macrophages. In chronic inflammation, you'll see macrophages, lymphocytes, and plasma cells. Very easy distinction. When you look at the slide and you want to determine if a inflammatory process is acute or chronic, you see polys is acute, you see lymphs is chronic. But keep in mind that if you're dealing with a viral infection, acute viral infection, you will not see polys. You will see lymphocytes. If you're dealing with an parasitic infection or an allergy, what you're going to see? You're not going to see polys. You will see some polys, but the picture will be dominated by eosinophils. If you're dealing with a hypersensitivity reaction, you will not see polys. It is an acute reaction, but you will not see polys. You will see plasma cells. So keep in mind that this is the rule, but there are exceptions. Now let's come back to the morphologic features of chronic inflammation. You will, aside from mononuclear cells, you will see tissue destruction induced by persistent offending agent or by the inflammatory cells. And you also see some degree of healing by the replacement of damaged tissue by connective tissue that we call that fibrosis, and by proliferation of small blood vessel. We call that angiogenesis. Angio means blood vessel, angiogenesis, the genesis of the blood vessels. How do you call the genesis of the lymphatics? Lymphangiogenesis. Angio, blood vessel, lymphangio, lymphatic, lymphangiogenesis. All these words have a lot of logic in them. Here's the comparison between acute and chronic inflammation. I hope that by now you can recognize the picture on the left as being an acute inflammation. We just looked at it. Alveolar spaces lined by these walls which contain dilated blood vessels, congested vessels, and inside you see these neutrophils filling the alveolar space. Now, on the right side, you see a picture of chronic inflammation. The first thing you will notice is that there is no classic alveolar space. All the alveolar spaces were replaced by these irregular shaped spaces lined by this cuboidal epithelium. What else do you see? You see this collection of inflammatory cells right here. And also in between, you see these pink cells, these pink areas. That is fibrosis. This is connective tissue which replaced the normal lung parenchyma. Also, you can see that not only you have this collection of inflammatory cells, but they spill into the tissue. These are also some inflammatory cells. Now that's a feature of chronic inflammation. That's the look of chronic inflammation. And I just put the slide here to show you, just a quick reminder, how the normal lung should look like, which is not what you just saw in those two pictures of acute and chronic inflammation. Now let's talk about cells. Lymphocytes, 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 and a lot of lymphocytes here. And among them, you see these macrophages, bigger nucleus, lighter in color, elongated. They can be elongated, and if you can, stringy. And if you can make out the outline of the cell, you see they have variable shapes because they just wander around. And if they fed, you can also see some vacuoles. Now, I took this from Utah website, from their library. They say this is a chronic endometritis. This is the endometrium, the lining of the uterus, pretty atrophic here. But what's important here, I want you to tell me what cells are these. I'm going to start describing them. Ovoid, eccentric nucleus. There's a clearing next to the nucleus, the perinuclear half, and clock face, eccentric nucleus. Plasma cells, yes, you got it. Okay. Now, those were lymphocytes and plasma cells. Let's talk about macrophages now. Macrophages will be the dominant cells in most chronic inflammatory reaction. These are the professional phagocytes. They are derived from hematopoietic stem cells and from progenitors in the embryonic yolk sac and fetal liver during early development. So they exist as monocytes. These are the circulating cells of the lineage, which have a half-life of about 1 day, and they begin to migrate in tissue in early inflammation, transforming in macrophages, and at that time they become activated. And there's also resident macrophages, which are diffusely scattered in most connective tissue. And you know them by different names according to the tissue. They're called Kupffer cells in where? Where's Kupffer cell, in what organ? Yes. Sinus histiocytes, microglia, alveolar macrophages. They have many functions. They contribute to the inflammatory reaction by destroying foreign invaders and tissues, by secreting cytokines and growth factors that act on various cells. They also activate other cells, notably T lymphocytes. All right. Well, I just mentioned activation. Activation is a very important process, and there are two ways for the monocyte to become activated. There's M1 and M2. M1 is the so-called classically activated macrophage. This is induced here. This is M1. This is induced by microbial products and cytokines, particularly interferon gamma. And once activated through this pattern, they phagocytose and destroy microbes and dead tissue. Very importantly, they can potentiate inflammatory reaction. The alternatively activated macrophages, that's the M2 one, it's called M2, it's induced by cytokines other than interferon gamma. They're induced by cytokines such as interleukin 4, interleukin 13, produced by T lymphocytes and other cells. And while activated through this way, they will have anti-inflammatory effects. They will be important in tissue repair because they promote angiogenesis, they activate fibroblasts, and they stimulate collagen synthesis. In other words, they will be very important in the repair process. About lymphocytes, how do they participate into this reaction? Well, they amplify and they propagate chronic inflammation. And if you look at this picture, you start here. You see a macrophage which is classically activated and in turns will present antigen to T cells and will secrete cytokines, and they will activate the T lymphocytes, which in turn will produce cytokines that recruit macrophages and others that activate the macrophages. So they amplify, they work together. There's an interaction between macrophages and lymphocytes. The lymphocytes will secrete inflammatory mediators. The plasma cells will produce antibodies. They also participate in cell-mediated immune reaction. And as you see in this picture, they will interact with macrophages in a bidirectional way, propagating the chronic inflammation. There are other cells involved in this chronic inflammation. Eosinophils, I mentioned already. They are abundant in immune reactions mediated by IgE, allergies, you know them as allergies, and they're also important in parasitic infection. You will see a lot of them. These are the eosinophils, bright red, small granules, almost covering sometimes the nucleus. Mast cells arise from precursors in the bone marrow. They're widely distributed in connective tissue, and they release mediators and cytokines. They participate in both acute and chronic inflammatory reaction. And you can also see neutrophils. I told you neutrophils are specific, and you see them in acute inflammation, but you can see them also in chronic inflammation. They can be induced by persistent microbes or by cytokines and other mediators. And when you see a lot of polys of neutrophils, you call that pattern of inflammation acute on chronic. Here's an example of Hashimoto thyroiditis. On the left side, you see the normal thyroid tissue with the follicles. On the right side, you will see extensive infiltration of the gland by these inflammatory cells, by lymphocytes and plasma cells, with distortion, destruction, obliteration of some follicles. Here's a definition of success, said Winston Churchill. Success consists of going from failure to failure without loss of enthusiasm. All right, now let's move on to the last part of the lecture, granulomatous inflammation. This is a morphologically specific pattern of chronic inflammation. How do we define a granuloma? It's a cellular attempt to contain an offending agent that is difficult to eradicate. So the body cannot get rid of it, but will try to contain it. How do we histologically define a granuloma? A granuloma is a collection of activated macrophages described as epithelioid cells. Epithelioid means they look like epithelial cells. How is that? Because they have a lot of pink cytoplasm. They plump and they have a lot of pink cytoplasm. I'm going to show you pictures. You may or may not see giant cells, which are formed by fused macrophages. You see a color of T lymphocytes around these activated macrophages. And in all the granulomas, you also can see a rim of fibroblasts. In the center of a granuloma, you may or may not see necrosis. So when you see central necrosis, we call that a caseating granuloma. And as you learn in TB, this is specific for TB. That's the classical example of a caseating granuloma. That's not the only one, but that's the classical example. So this necrotic material will appear as amorphous, eosinophilic, granular debris with lots of cellular detail. Now let's take a look. A picture makes more than 1,000 words. This is the center that I just described as necrotic. In this center, you do not see any cellular outline. This is just a necrotic area. Around it, you see all of these epithelioid cells. All of these are activated macrophages, plump with a lot of pink cytoplasm. And around it, you may see this rim of lymphocytes. Here's another one that's non-caseating. This is caseating. I see the necrosis in the middle. There's no necrosis here. I just see a lot of epithelioid cells, a lot of activated macrophages with a rim of lymphocytes. This is called a non-caseating granuloma. Epithelioid cells, a close-up to show you what we mean by that. That's a lot of pink eosinophilic cytoplasm and this elongated, stringy, if you want, nuclei. We classify the granulomas in two main types, immune or foreign body granulomas. Immune granulomas, in cases of immune granulomas, the inciting agent cannot be readily eliminated. They are capable of inducing a persistent T-cell mediated immune response, T-cell cytokine, chronic leading to macrophage activation, and the classical examples and most important examples that you have to remember are TB, leprosy, syphilis, cat scratch disease, some fungi. It's really easy to remember if you think that the agent cannot be readily eliminated. Now, foreign body granulomas, in turn, they form in response to relatively inert foreign bodies, such as talc or sutures. They form in the absence of a T-cell mediated immune response, and they form when foreign material is too large to be engulfed by one single macrophage. And I will show you a few examples. Now, this is a table which gives you a lot of detail about different diseases that can present with granulomas. For instance, tuberculosis, caused by Mycobacterium tuberculosis, as you know, the reaction will be a caseating granuloma. Leprosy, non-caseating granuloma. The cause is Mycobacterium leprae. Syphilis, Treponema pallidum is the cause. Central cells are necrotic. These are called gumma, if you remember. Cat scratch disease, you can see some central granular debris. Sarcoidosis is the typical example of a non-caseating granuloma. And also other instances such as Crohn's disease, you can see also granulomas. Here's a so-called miliary pattern of granuloma. Do you recognize the picture now? It's similar to what I showed you before when I asked you what organ is that. That was a case of bronchopneumonia. And those little white spots that you saw there were microabscesses. Here, these are granulomas. So this, in case of a poor immune response to agents producing granulomatous inflammation, there can be such an extensive spread of the infection with the production of this pattern called miliary pattern of granulomas. And this is another example of grossly how these granulomas look like. And in H&E, these are the granulomas. And this is a close-up of this Mycobacterium tuberculosis infection with formation of granulomas. Here you can appreciate the necrosis in the center of this granuloma. This is a multinucleated giant cell, which I told you may or may not see in a granuloma. And in order for you to make a diagnosis of the TB infection, you will do a acid-fast stain, and all of these red little spots will be diagnosis for you will show you the presence of the Mycobacterium tuberculosis. The question here is, where are you going to see this bacilli? In which area of this tissue? Here, in the necrotic center. That's where your chances are best to find this bacterium. Here's an example of a tuberculous granuloma showing a central area of necrosis surrounded by this multinucleated giant cells, also called Langhans cells, epithelioid cells, all of these epithelioid cells, and you can see some lymphocytes, a rim of lymphocytes surrounding it. So I gave you the definition of an epithelioid cell, a modified macrophage, which is characteristic in this granuloma. Here's the close-up. I hope you can appreciate the central area, which is amorphous. I cannot see any cellular outline. So this is the area of necrosis. Around it, I see this activated macrophages, plump, a lot of cytoplasm, and around them, I see this rim of lymphocytes. Here's another example of sarcoidosis. Two granulomas in sarcoidosis. They are non-caseating. I don't see any necrosis in the center. I do, however, appreciate some multinucleated giant cells. And here's a granulomatous reaction to foreign bodies. This is the foreign body, and I can see multinucleated giant cells around them here and here, trying to engulf this foreign material. And here's the question for you. There's something here that shouldn't be part of the normal tissue. Anybody knows what this is? And this cell here, or whatever this is surrounded by a multinucleated giant cell who's trying to contain it, forming a foreign body granuloma. Same thing here. Anybody knows what this is? It has this little striation here, and it's surrounded by this multinucleated giant cell who's trying to engulf it. Here, this is the foreign body, surrounded by this multinucleated giant cell. Here, I see some crystals. Can you appreciate them? I'm going on the outline. Surrounded by multinucleated giant cells. Cellulose in the lung, aspiration pneumonia. Fragment of a muscle in a lung, aspiration pneumonia. Sutures, also trying to be contained. And in the breast, foreign body in the breast. I think this is your last Zen moment. Apparently these two were not very friendly one to another. Churchill and George Bernard Shaw. George Bernard Shaw said, I'm enclosing 2 tickets to the first night of my new play. Bring a friend, if you have one. Churchill said, cannot possibly attend first night. We'll attend second, if there is one. And that concludes the second lecture. Thank you.